Hi, this is Dr. Jackie coming back to you talking about hypertension today for GPs and their patients. So this is the second video. I might make this longer so we can just finish. I'll try and make this at least half an hour. So we're talking about now patients' views and the question that they may ask. And this one we're going to ask about talk about patients said I had hypertension in pregnancy. What is my risk of developing hypertension later in life? So it says it's well known that women who have hypertensive disorders in pregnancy, that's gestational hypertension, preeclampsia, eclampsia, or HELP syndrome, are at risk of developing hypertension later in life. A massive cohort study has now quantified the risks and looked at how quickly hypertension recurs. That's according to BMJ 2017, page 358. It says about a third of women with hypertension in pregnancy developed hypertension in later life. So hypertension may present as soon as 1 year after delivery. Another cohort study looked at women who had had hypertension in pregnancy to identify what factors increased the risk of hypertension in later life. That's BMJ 217. The main risk identified was obesity. The researchers estimated 25% of all cases of hypertension in later life were attributable to obesity. Modifying lifestyle to reduce obesity would reduce the number of women who developed hypertension later in life. So the accompanying editorials reminds us these women need regular monitoring, but they don't specify what this means. So this is the BMJ 2017, page 358. So we should ask ourselves as GPs, do we code hypertensive disorders in pregnancies? And do we ensure that these are monitored, that we monitor these women for hypertension? Or do we do this ad hoc, or do we want to be more proactive? Should we monitor this every year, every 6 months? So we need to just there should be a school for thoughts for women who were diagnosed with hypertension during their pregnancies. Okay, so we're looking at poor compliance. The BMJ 10-minute consultation suggested if we are finding patients who are not taking their antihypertensives, we should, according to the BMJ 2016, explore reasons for not taking medication, ask and listen, discuss risk, for example, using the Q risk tool online to show happy or sad faces to look at risks. Yeah, do the Q risk with the patients, and then discuss the benefits of lifestyle change, which may result in needing less medication. And also we need to look at rationalizing medications or changing them to reduce side effects. And also we can encourage the patients to do home monitoring as a way to empowering patients to take control. Using motivational interviewing as a way of empowering people to improve adherence. Okay, so none of these will come as a surprise to us, but we know that, but I know that I'm less good at the asking and listening and quick to start telling. Most GPs are like that. Okay, so blood pressure variability matters. Okay, let's look at that. Declaration of interest. One of our team, yeah, okay. This is what the reading from the leaflet. One of the team is an author of this paper. So we know that mean blood pressure increases cardiovascular risk. Those with a mean clinical reading of 160/100 are at a higher risk than those with a mean clinic blood pressure of 130/60/80. However, this meta-analysis looked at variability of blood pressure in association with cardiovascular risks. That's in BMJ 216, page 354. It isn't the first paper to do this, but the authors tried to get around the shortcomings in previous papers. That is by adjusting for the mean blood pressure. Blood pressure variability is how much it differs from reading to reading. The study showed that having significant variation in clinical systolic blood pressure increases the risk of all-cause mortality, cardiovascular mortality, and cardiovascular events. The increased risk was slight, about 1.2-fold. The authors point out that it is hard to know exactly what to do with this piece of information in daily practice at present. Very helpful. The accompanying editorial says that, that is in BMJ 216, 354, I1 1490. It says, although some studies have shown that certain drugs reduce blood pressure variability more than others, for instance, calcium channel blockers are the best, this should not affect our decision about which antihypertensive to use. The study reminds us that the risk may be higher than the actual clinic blood pressure suggests if there's a significant variation. Risk tools may start to incorporate variability in them, but until they do, this trial doesn't change our practice. Okay, this is just a reminder that I'm, looking through the paper from the GP CPD online, and I'm just looking at on the hypertensive PDF. So NICE guidelines on hypertension. So NICE, in conjunction with the British Hypertension Society, published new guidelines in the management of hypertension in 2011. So let's see what they said. There's some key changes. The key changes were, I remember this paper was this year, 2018. This is the latest one that we research on that. The key changes: ambulatory blood pressure is suggested as the investigation of choice for all suspected hypertension. That's a NICE guidelines. So home readings are an alternative if ambulatory blood pressure cannot be used. Clinic BP readings are no longer recommended for diagnosis of hypertension. However, they can and should be used to monitor responses to treatment. Great. So why shift to ambulatory monitoring? Because it is better. I mean, that's what I generally use. It's more robust data is available, looking at cardiovascular endpoints, and over-diagnosis rates are lower. Home readings over-diagnose. 14% of people, clinic readings are whooping, and clinic readings, 14% of people, and then in the clinic are whooping 25%. So it's also more cost effective in the long run in terms of pounds saved and QAL wise, as was demonstrated in a modelling study based on typical UK general practice patients. That's according to Lancet 2011. This included initial investment costs, the staff costs of clinic versus home, and versus ambulatory monitoring. Okay, the other thing is that the threshold blood pressure for offering drug therapy has changed, partly reflecting the move to ambulatory blood pressure monitoring. Diuretics have moved to third-line drugs after ACE inhibitors and calcium channel blockers. Thiazide-like diuretic of choice is now indapamide rather than bendroflumethiazide or hydrochlorothiazide. The reasons for these are discussed we'll discuss them later in the frequently answered questions. However, NICE says that those already established on bendroflumethiazide or on hydrochloroside need not to be changed to indapamide. Okay, so let me look at the frequently asked questions, and we look at why the reasons for these changes. Give me a second. Okay, I've looked into the frequently asked questions section. I think that's going to take long. I'll just do a special video just on that, on the frequently asked questions. So So basically, these guidelines say that they do not apply to these. So let's read that. The thiazide-like diuretics is like diuretic of choice is now indapamide rather than bendroflumethiazide or hydrochlorothiazide. The reasons for these are discussed in the frequently answered questions section, so we will discuss that there. Just give me a pause. So just go on there. So the reason for this, why the change in first-line diuretics? So thiazide-like diuretics such as indapamides have other properties not shared with thiazides themselves. So for example, thiazide-like diuretics affect carbonic anhydrase in the kidney 10,000 fold more, and also have a different effect on platelet aggregation and angiogenesis. However, the clinical significance of these differences is not fully known. So many of the data on the benefits of bendroflumetazide came on from old trials where doses of 10 milligrams were used. There is no evidence for the use of bendroflumetazide at 2.5 milligrams showing improved clinical outcomes, although there are some trials showing it reduces blood pressure. Of course, this doesn't mean that it doesn't work, but why use a drug for which we haven't the evidence when there are other drugs that have shown evidence of benefit? Okay, so what do we do with people already on bendroflumethiazide? Methiazide. NICE says that there is no need to change for those established on bendroflumethiazide if their blood pressure is controlled. Okay, so if the blood pressure is controlled, we don't have to change it. Just give me a pause. I just want to make sure my pronunciation of this word. Okay, I've just gone on what do you call it, on Google and just checked on the bendroflumethiazide. Okay, I came across this. I was actually looking to how to spell it. So let's just quickly I just wanted to remind myself of all those physiology. So they're saying it's formerly known as bendrofluazide. Trade name is Aprinox, and it's a thiazide diuretics used to treat hypertension. So it's a bendroflumetazide is a thiazide diuretic which works by inhibiting sodium reabsorption at the beginning of the distal convoluted tubule, DCT. Water is lost as a result of more sodium reaching water is lost as a result of more sodium reaching the collecting ducts. Bendroflumetazide has a role in the treatment of mild heart failure, and although loop diuretics are better for reducing overloads. The main use of bendroflumetazide currently is in hypertension. Part of the effect is due to its vasodilatation properties. So the adverse side effects of that's the ring. That's how it looks like. You can see it there. And then the adverse side effects of bendroflumethazides are postural hypotension, hyponatremia, hypokalemia, hyperkalemia, gout, impaired glucose tolerance, impotence, fatigue, pulmonary edema, and pneumonitis. Rare adverse effects are thrombocytopenia, granulocytosis, photosensitivity rush, pancreatitis, and renal insufficiencies. So alcohol and bendroflumetazide. So bendroflumetazide is known also to have adverse interaction with alcohol. It's advised that those using these diuretics should abstain from alcohol consumption during use, as it is possible to experience a sudden drop in blood pressure, especially in standing up, an effect known as postural hypertension. So other consideration, bendroflumetazide should not be used by pregnant women or women who have just given birth due to the nature of the medication. It is possible for it to pass into breast milk and consequently to the child. It is also known that bendroflumetazide suppresses the production of milk. of breast milk, pregnant or lactating women with hypertension may need to discuss with their prescribers as to which alternative treatment may be suitable. So bendroflumetazide may also impair the user's motor skills. Therefore, it is important to be aware of its effect and take caution when operating machinery or of driving. Okay, that's from Wikipedia. Okay, I think that's all we'll do on that one. And let's go back to the frequently answered questions. The other question was, why are diuretics now only third line? So NICE based this recommendation on a single trial, that is the ACCOMPLISH trial, and fully acknowledged this fact. ACCOMPLISH was a large random controls trial over 11,000 people randomized to an AC inhibitor and CC and calcium channel blockers, or an AC inhibitors and thiazides. Okay, and thiazide diuretic, and showed in the New England Journal, New EJM, in 2008. ACE plus calcium channel blockers was significantly more effective at preventing MI compared to ACE plus diuretics. The trial was stopped early because of this. There was also fewer withdrawals from the study on ACE plus calcium channel blockers combination compared to ACE plus diuretics, suggesting better tolerability. This contradicts the All-Hat trial, which showed that thiazides, in this case the thiazide-like diuretic chlorthalidone, was as effective as ACE inhibitors and calcium channel blockers in preventing fatal and non-fatal cardiovascular endpoints. So circulation, that is Circulation 2011, that's a reference point. However, in the All-Hat trials, trial drugs were being used predominantly as single agents, not in combination as in ACCOMPLISH trial. The ACCOMPLISH trial therefore probably better reflects real life situation where combination therapies are used. So the other thing we look at is the question was thiazide and heart failure. The relegation of thiazide to third-line therapy is interesting because there is some evidence around their roles in preventing the development of heart failure. And remember, hypertension is a major contributing factor in the development of heart failure, as we said earlier. A meta-analysis of almost 250,000 patients with hypertension in 26 trials looked at which treatment of hypertension was most effective at reducing the development of heart failure, and found that diuretics were the most effective drug at preventing heart failure, and better than ACE inhibitors and ARBs. So ARC Interim Med 210. And then that's a reference. This is confirmed in a recent Cochrane review. That's in Cochrane 215. And a massive meta-analysis in Lancet 215. Are we missing a trick here? Should we be using thiazide-like diuretics sooner in hypertension? So again, let's talk about that's a food for thought. And there's again the thiazide and bone protection. Since the NICE guideline was published a trial suggested thiazides offer some bone protection too. Using data from All-Hat trial, and researchers looked at the incidence of hip and pelvis fracture according to the class drug used. That is JAMA interim. During the 5 years of trial, thiazides, that is chlorthalidone, reduced the risk of hip and pelvic fractures compared to amlodipine or lisinopril. Number needed to treat was 5 over 5 years to prevent 1 fracture. 5 years after the end of one of the trial, a time in which doctors were free to prescribe any drug, thiazides were associated with a non-significant reduction in hip and pelvic fractures compared to amlodipine, but not lisinopril. The authors describe this as a legacy effect. Is this another reason to use thiazides? Okay, so let's do this step 4. Let's look at the step 4. We look at the step. So that's it. That was the questions we were discussing on the frequently asked questions. I'll stop there, and in the next video we'll just go on with discussing further about the NICE guidelines, the latest NICE guidelines on the treatment of hypertension. Okay, thank you for listening to this, and I'll see you in the next video. And this is Dr. Jackie Akande, and I hope this is of benefit to you. Okay, bye. See you in the next video.